Welcome to Altea Talks, the brand new podcast series being brought to you by Altea, the unique provider of combined insurance and risk management solutions designed exclusively for the medical, allied health and care sectors. I'm going to be your host, Will Marshall, and I'll be joined in this series by some of the leading movers and shakers from across the sectors. My guests are going to include practitioners and professionals, regulators, clinical risk and governance specialists, and an array of legal experts who are going to help us get to the heart of the hottest topics affecting health and social care sectors today. So, if you're looking for frontline knowledge and expertise, if you want valued insights into these most dynamic, challenging and rewarding of sectors, then look no further because you're in the right place. Welcome again to Altea Talks. Hello and welcome to this latest edition of Altea Talks. This week I'm delighted to be joined by Dr. Alice Ashby in the first part of our special double episode in which we analyse some of the key trends, issues and features affecting the world of psychiatry. Dr. Ashby is a consultant psychiatrist who's licensed to practice through the General Medical Council, the GMC in this country, and also through the Saudi Commission for Health Specialities. Dr. Ashby is a fellow of the Royal College of Psychiatrists and has over 16 years' experience of working with adults. In her practice, she specialises in liaison psychiatry, managing patients with neurological conditions, as well as providing fertility support and maternal mental health services. Alice is also the Associate Medical Director at the London Psychiatry Clinic, a centre which hosts a team of about 50 consultant psychiatrists and therapists with a very wide range of expertise covering most fields within psychiatry, including general adult, psychiatry, child and adolescent, neuropsychiatry, medical psychotherapy, and addictions treatment. Dr. Ashby, a very warm welcome to Altea Talks.
Thank you for having me. It's good to be here.
It's a pleasure. I think if we start, just to kick us off, for people who don't know you, perhaps you would like to tell us a little bit about yourself.
Sure. So I'm a psychiatrist for adults. I see people 18 and over. And I trained in England, in Bristol and in London. And I worked here in London for many years. But life's taken a little bit of a turn in that I moved with my family to Riyadh for family work reasons, not my own. And so I'm mostly working remotely now for London Psychiatry, although I'm here in London now and pop back every so often to see family and friends. My interest in psychiatry you've already mentioned, but very much when I worked in the NHS, I worked in general hospital. So I was in the emergency department, went up to obstetric wards where people were having babies and to the medical and surgical wards. So I very much saw people who had physical health conditions as well as mental health conditions, or they were coming into the emergency department with psychiatric emergencies, or sometimes was covering the labour ward for people having babies. So that was my job then. My job now is a bit more general and an outpatient job, of course. And I do a lot of my work on video calls just necessarily because I'm not in the country some of the time.
Yeah, thank you. I mean, was there an early memory of being attracted to psychiatry, or did you have an aha moment when you realised that this was going to be your calling?
That's a really good question. I was always really interested in how people thought and what made people who they were, how our personalities became our personalities and how people work together in teams and how friendships were made. I was always really interested in that. And I was thinking about doing a psychology degree when I was at school. I actually got some careers advice at school that said, do you know, it's much, much more difficult to get into a DCLN Psy, the qualification, PhD level qualification that you need to be a clinical psychologist, much more competitive at the time that I was applying than it was to be at medical school, to be a doctor and then go on to psychiatry training. And maybe you want to think about that. And in the end, I thought, well, maybe I'll keep my options a bit more open. So I applied to medical school, but I maintained the interest in psychiatry. And I think like many people, like most of us, I know friends and family who've had difficulties with their mental health. And so I think that's influenced my career choice, of course.
Yeah, thank you. You talk about the importance of creating a comfortable, relaxed and safe environment for your patients. How do you ensure that patients feel at ease during their first appointment, especially if they're anxious about the types of questions they're going to be asked or the process in general?
Yeah, that's a really good question. So we send quite a lot of information out to people before we start, before they book an appointment, actually. Part of that for us is making sure as a private service we're getting someone to pay for what we're doing, obviously. And often it's the person themselves or their family that are paying, or an insurance company. So it's really important for us that we know that people are signing up to what they know they're signing up to, and that they know that what they're paying for in a kind of we're selling something kind of sense, a bit like you would want to make sure that that a sofa you bought was exactly what you wanted to buy. So we send quite a detailed new patient letter to people with lots of details about what the appointment is and what the kind of terms and conditions are around that. And people have to sign that actually before they see us. So we are sure that they've read it. So people have quite a lot of sort of technical data. I think there's the much more kind of feeling side of it, and people are still quite nervous, I think, when they come and see us, and there are lots of myths and misconceptions about psychiatry. A lot of it's actually just sort of showing people pictures of the rooms that we have if we're doing face-to-face work. So I think people have ideas that maybe you're going to lie down on a couch. I mean, we have sofas, but in our clinic rooms, but you sit on them, you don't lie down, in case anyone's wondering. And I think video consultations, people can be a bit more comfortable in that sense sometimes, because they know they're going to be in their own, they can choose where to be. They can choose to be in the office or in a quiet room in the office, or they can choose to be at home in their own comfortable space. So I think that starts off a bit more safe feeling for some people, especially younger people who've really grown up using computers. So that feels like a very safe place, I think, for younger people, particularly who've, as I say, grown up with a computer being part of their lives and a smartphone.
And we're all much more comfortable with that now, aren't we?
Yeah.
Even those of us who didn't grow up with computers have spent the last 3 or 4 years doing the majority of our work meetings that way, and a lot of our interactions that way. And it's always surprises me how quickly that has become such a natural thing to do. Whereas if you think back to sort of pre-pandemic, it was maybe a little bit awkward to have a video call with someone, and there's none of that now.
No. I always tell people, well, it's true. And my master's is in medical ethics and law, and my dissertation was on telemedicine in psychiatry. So I spent a year of my life thinking about the sort of the risks and the benefits of doing more online psychiatry, which people were extremely nervous about at that time. It was totally technically possible. It was about 10 years ago, but it was virtually not done because people had lots of worries about the potential safeguarding risks or the potential risks that you wouldn't really be getting the whole picture. I know you're going to come on to talking about this.
Well, I mean, we can talk about it now. I mean, it's a very interesting and topical area. I'd like to ask you about that. You treat a lot of your patients online now, or remotely, sorry. And I just wanted to ask you, do you think that it's as effective to provide treatment remotely as it is to provide it in person? Are you able to pick up things like a person's body language and the importance of the sort of the overall presentation that you get through an in-person consultation? And do you feel that there are inherent risks by having a remote practice? Or is it something that is equally effective in your view?
That's a really good question. I think the first bit is there are different types of in-person consultation, and there are different types of telemedicine. So I think in terms of face-to-face, we don't get the whole of the picture of someone when we see them in clinic. That's always been true. When I worked in NHS community mental health teams, it was always better to go and see someone as a home visit if you could, or at their office or in their local community, because you've really got much more of a sense of them than when you were sitting in a slightly institutional room. So you do miss something in a clinic appointment as well that you don't get in a more home visit setting. So not all face-to-face appointments are the same. In the same way, not all online appointments are the same. So of course you get more of someone's body language when you're in video compared to on a phone call or in a kind of WhatsApp message or something like that. So there are different sort of forms of, I guess, telemedicine. But of course, it depends on the condition that you're talking about. So of course, there are things that I used to specialise in and used to do every day of my working life that I can't do in my current job. So I used to work in A&E, so I used to see people with acute psychosis and who were presenting in emergencies with self-harm. And of course, I don't do that kind of emergency work now because I can't respond in quite the same emergency way. And that stuff is better done face to face. So yes, my practice has slightly changed, but there are certain conditions in psychiatry for which I think telemedicine has actually made it more accessible to people. So, I always say that I spent that year of my life doing the dissertation, pondering the pros and cons and the legal ramifications and where does your duty of care stop? And then COVID happened and everyone clicked their fingers and it just happened and people stopped worrying about it because it was the only way that we could access care. And actually, it stayed because it's still a really accessible way to access healthcare. So where you used to have to take half a day off work for a 1-hour therapy appointment, you can now squeeze it in between your board meeting and your next client appointment. So people find it a lot less stigmatizing, a lot more private and confidential than walking into a building that has a sign on the front of it. It means children who don't have to take as much time off school, they can fit in an appointment even sitting in a private room with the school nurse even. So it's a lot more flexible, a lot more accessible, I think, for certain conditions. But of course, it depends what condition you're talking about.
Yeah, of course. And do you find with just generally with telemedicine, with remote consultations, that there are further questions you have to take? You have to be more careful about taking a proper history from someone or really sort of getting to the bottom of what it is that has caused them to come to see you than you might have to do if you were sitting face-to-face opposite them.
That's a good question. I think broadly I'm asking the same questions. I might have to ask some people to clarify some things if I'm not getting it from being in the room with them. But so I suppose I would always have asked questions even face to face around someone's mental state examination. So the mental state examination is our equivalent in psychiatry of physically examining someone. And of course, a lot of that is observing someone's appearance and their behavior and how restless or otherwise they are or calm they are and how close they're standing to you compared to what you might expect, that kind of thing. And you do miss some of that stuff. And I might ask then a relative to comment on those sort of things if they're in the room with them. But I would always have tried to clarify that I was getting the right end of the stick. So I might have said to someone, "You look really sad right now to me. Am I understanding that right or am I getting that wrong?" And I would have always said that face to face as well as online. But yeah, I might use things like that a little bit more to clarify that I'm getting it right.
Yeah, because I know you place a huge amount of emphasis on the importance of having a personalised, patient-led approach that focuses on understanding the individual patient's unique experience and concerns, and you don't have a predetermined set of questions that you ask them. How does that approach, in your view, benefit the patient, and how does it help to build trust between the clinician and the patient, the therapist and the patient?
Yeah, that's really important. Whether you're paying for your care privately or not, or whether you're having it in the NHS, you're the person that's experiencing it. It's your appointment. And we can write a list of textbook criteria that make an illness, but actually everyone's experience of that illness is going to be different depending on their own life experience, their personality, who they've got around them to support them. So all of those things are what we're looking for when we assess someone. And I always start my appointments. Actually, I know you're going to come back onto this, and it touches on your point of how do I make people feel comfortable. One of the absolute first thing that I always say, as any of my patients will tell you, I sound a bit like an insurance salesman sometimes, I think, with all my small print, but I always start by telling people what I'm going to do with the information that they give me before they tell me anything. And I know you're going to come back onto data protection and kind of confidentiality, so we can talk about it then. But I always think that's the most important thing. What am I going to do with all this sensitive and personal information that you tell me? So I tell people about that to make sure they understand. But the second thing I say, move on to, is kind of why you're here. What's the biggest problems for you? Because if I start where I think your biggest problems should be, I kind of miss the point right from the beginning. So,
do you ask them what they think recovery might look like for them?
Absolutely. Yeah. So we absolutely would talk about people's goals, and that can be really different for different people. So for some people, that's feeling secure in a relationship. For some people, it's a particular work goal. I think quite unique, quite differently in this clinic, we tend to see quite a lot of people who are quite high pressured jobs at work, who've been told before, you just need to leave your job, that it's too busy, and that's why you're stressed. And we're never going to beat around the bush and sort of say, oh no, don't worry, your job's not stressful. Clearly it is, but I think we'd like to think we have a bit of a specialism in trying to work around people's high pressured jobs to make them perform the best that they can whilst keeping themselves healthy. That's one of our specialties. So we often are talking about work performance, I think, in our clinic. But yeah, it can be all sorts of different things to different people.
Yeah, sure. And how do you balance the use of medication with other therapeutic options in your practice? And what steps do you take to ensure that your patients are fully informed about the benefits and risks of using medication and, with the eventual goal of reducing medication where possible?
Of course, that's a really great question. So I think when one of the most common questions people always want to ask me is, what's the difference between a psychiatrist and a psychologist? That's usually the first question. And I suppose the stereotype of that is that the psychiatrists, as the doctors, are the ones that are prescribing medications, whereas the psychologists are doing talking therapies. And that divide doesn't always work as a definition, because lots and lots of psychiatrists do talking therapies. Psychologists don't tend to be non-medical prescribers. Lots of other people prescribe as well as doctors in the UK. So we have a pharmacist who's a prescriber, Salma Ali, in our clinic, whose specialism is around ADHD. So she does a lot of our ADHD titration. So lots of people who are not doctors who become non-medical prescribers. So those kind of traditional lines, I suppose, are not necessarily in place anymore. And I think all of us, I think there's a kind of stereotype of doctors being the very medicalized people who are always prescribing the drugs. But actually, I don't think those psychiatrists really exist anymore. I think all of us are trained in a very biopsychosocial model, which means if you can imagine a triangle where one point of the triangle is biological treatments, which might be medicines, but there are all sorts of other biological treatments that we're thinking about now, including things like TMS, transcranial magnetic stimulations. Then there's the kind of corner of the triangle, which is around psychological therapy, so talking type therapies. And then there's the third point of the triangle, which people often miss, which is probably the most important, which we label social, but it means everything else that makes you human and makes life worth living. So having healthy relationships is part of it, which you might talk about in therapy, but just having all your basic needs. So having somewhere safe to live, having a job that you find rewarding and that gets you enough money to get by, all of those kind of practical things about life. And you need to have all the bits of the triangle in place to make things work. That doesn't mean that everyone needs medication by any means or by any stretch of the imagination. Ditto, not everybody needs talking therapies, but you've always got to be thinking about that triangle in terms of treating people, and that's the way that I would approach things. So, and I'm never going to be one of those people who thinks that a medication is going to solve everything for people. It doesn't magic away what's happened to you in your past. It doesn't make you forget all of that stuff. That's probably a myth that kind of carries around things like antidepressants. It doesn't solve your relationships or help with that really, but it does help you to get to the point where you can access therapy. So if you're very, very depressed and you're in bed all day and you can't get the energy and motivation to even get up, you're not going to make it to psychological therapy, even if it's on your computer. And even if you manage to open the computer, you're not going to make much of it psychologically. So I think medication can get you the first step of the way, in my head, for things like depression and anxiety. It can also depend on the type of condition that we're talking about. So there's no doubt that for ADHD, for example, medications are spectacular to this day. And including all of that time working in A&E with, acute psychiatric emergencies with people with thoughts of self-harm. To this day, the only person who said to me, "You've saved my life," was a 5-year-old with ADHD. I don't do child psychiatry now, but it was during training, and the medications that we use for ADHD can be absolutely spectacular.
Really?
Probably the most spectacular drugs in psychiatry.
Which drugs are we talking about?
The main drugs that we would use are the stimulant drugs, so the methylphenidate type drugs and the lisdexamfetamine type drugs. Those are the first prescribed.
And how do they help? What do they do?
Why do they work? So if you get the right drugs into the right people, for people with ADHD, you're thought to have not enough dopamine, which is a chemical that's a neurotransmitter, so a chemical that transmits messages between one nerve cell and another nerve cell in your brain. Dopamine is one of those neurotransmitting chemicals, and we think that the level of it in your frontal lobe, which is the area of your brain just behind your forehead, is too low. And that frontal lobe, that bit of your brain that's right under your forehead, does everything that makes us human. So it helps us to organise things and plan things and think ahead about consequences. It does language, all the things that sort of, as I say, make us different. We've got a bigger frontal lobe than most other mammals. And people with ADHD don't have enough dopamine in that area. So the drugs that we give increase the amount of dopamine, allowing you to do things like focus and do attention and concentration better. One of the reasons we're so pernickety, I suppose, about ADHD assessments, and that we have to do this quite long, detailed, thorough and very careful assessment, is that it's really important that we get the right diagnosis, because if you give those drugs, which are essentially stimulant medications, to the wrong person, it can make you elated, psychotic, because you have a normal dopamine level, and putting too much dopamine into that part of your brain can have a very different effect.
Yes. So just whilst we're on the topic of ADHD, what do you think about all of these fast referral services that are popping up that can offer a diagnosis seemingly very quickly in such serious condition, and one where the consequences of a misdiagnosis or giving medication to someone who doesn't necessarily need it can be so serious?
Yeah, it's a really good question. I think the first thing to say is that the waits in the NHS for ADHD are horrendous. In anyone's book, I've come across many children and people in their teens that are told that they have 3 to 4 years to wait, which could change the course of their lives. That will mean the difference between passing your final exams at school and getting into university versus, maybe leaving school because of your ADHD. So, and even though maybe we would see, I tend to see adults, even though we would maybe see adults as having a bit more time, actually that can also mean the difference between losing your amazing career, being sacked, versus being very successful and continuing, or even doing better. So those waits are horrendous. And the first point, I guess, would be anything that can help with that is good. So I've no kind of qualms with people trying to do things to make the process as efficient as possible. And I know there's no doubt about it. Our clinic, London Psychiatry Clinic, is at the top end of the price spectrum for having a ADHD assessment. That's no secret. You just have to look at anybody's website or our own. We do things in a very individualized way. So every single assessment is totally individual. We meet the patient. We write the report for that patient. And I'd be the first to say that we could probably be a bit more efficient in some of the things that we do. And I know that competing I wouldn't even say they're competitors, really, the other companies, because I think we just think of ourselves as a different sort of service. But some of the cheaper, more mass sort of services for ADHD, I know use a lot of things like AI to generate their reports, and that's got to be a good thing. We've all got to move in that direction. And I would say we probably should, as a clinic, be looking a little bit more at trying to use AI to automate things. We don't use that sort of thing at all. Every single report is handwritten by a clinician for us, which is what makes our service quite expensive. We'd like to think that we then provide a different service in the market. So we have a specialism in doing ADHD where it's more complicated. So I think if you're fairly well in terms of your mental health generally, and all you want is the ADHD assessment, then by all means go and get a general ADHD assessment from a faster, more AI-driven service. We'd like to think we have a bit of a specialty in where there's also depression and anxiety going on, or people are also thinking about getting pregnant and want to think about how those drugs might affect their pregnancy, or when they've also had a history of psychosis, but also ADHD, or they've also had a history of drug addiction and ADHD. So I think in a way we're providing a slightly different sort of service to some of those companies.
Yeah. Well, can I just ask you about ADHD? Why are so many people now being diagnosed with ADHD? Is it being overdiagnosed in your view, or is it what's causing this explosion in the numbers of people with this condition?
It's a really interesting question. I would be the first to say that I have slightly changed my mind on this. I think there's a certain element to it, and I've made a move from working in the NHS full-time, made a very unusual career move in the sense that I moved from working in the NHS full-time, I didn't do any private practice, to working full-time in a private service. And you almost, because of the NHS waiting lists, there is almost no private psychiatrist in the UK who hasn't moved into doing ADHD assessment, even if they didn't do it before, because it's where the work is, because of the pressures on the NHS services. So I didn't do this work at all in the NHS, but I've come into it from working here. And I'd be the first to say that actually I've learned a lot myself, and I think probably I'd been missing it before. There's no doubt about it. It has been a condition that has been missed in schools for a lot of people of our generation, particularly for women and girls that perhaps didn't present in the stereotyped way. I think what we think about when we think about ADHD is a total stereotype of a 8-year-old boy who's jumping off a garden wall and breaking their leg because they didn't really think about the consequences, who's very hyperactive. And I think we'd missed a lot of the more inattentive subtype people who tended to be more female, not always, of course, but we'd certainly been missing those people. And what happens, and what I seem to see in clinic, is that by the time people have got to adulthood, they have learnt how society needs them to be in order to get somewhere, in order to get through university, in order to get into work. And they've learnt to mask certain symptoms. So they no longer get up and down out of their seat, or they might do, or they might seem slightly fidgety in the office and it's slightly irritating, but everyone puts up with it. But they might have just learned how to mask it and sit on their hands rather than fidgeting. But that masking is exhausting and takes all of their energy. And then when they get home, that comes out in kind of frustration with a partner or depression or other things. Or, and I think we see this really commonly, some other life event happens and that kind of smashes apart all of that structure of masking that they've got going on. So they might have a bereavement or the breakdown of a relationship, or they'll lose a job. And then all of those things, those walls that they've put around themselves in terms of what society expects and kind of masking these symptoms that are there breaks down, and then they have a episode of depression or anxiety that's quite disabling, and then they'll come to us. So that sort of pattern is often what we're seeing.
So you think it is the prevalence of ADHD at the moment is because
I think it was always there.
It was always there.
I think it was always there, but we didn't recognise it. Yeah, I think it was always there. And I think I read a really interesting bit of research just last night via seeing it via social media that has come out of Brighton and Sussex Medical School, which linked neurodivergent traits, so either ADHD or autism type traits, age 7 and 9 in children. They'd used the Avon study, which is a kind of birth cohort study. So they got a whole load of people who are being born in the kind of southwest Bristol area to register on a birth registry, and then they've been following up these children through to their adulthood. Different researchers can then go and ask different questions of the cohort. So it came from that huge cohort study, which is a very solid bit of start to an evidence base. And they'd they'd found that if this cohort had shown neurodivergent traits, so traits that were suggestive of ADHD and autism at 7 and 9, they had a 2 times as likely to have fatigue symptoms at age 18. And so I think as a liaison psychiatrist, I've now started rethinking everything that I've done. Were all those people that I saw in a liaison psychiatry setting with fatigue or with other physical health symptoms, actually was that related to any neurodivergence? It's made me sort of think about a lot of patients I've seen before.
That's really interesting. And moving on to your specialism in liaison psychiatry and the mind-body connection, I think you've described the human mind as a fuse box that sometimes trips switches to protect itself, leading to physical symptoms instead of emotions. Could you share some specific examples from your experience in liaison psychiatry where patients' physical symptoms were closely linked to their psychological state?
Sure.
And how recognising that connection helped with their treatment?
Yeah, sure. So for all of us, physical health symptoms are part of emotion and part of the way that we experience emotion. That's completely normal. It's not necessarily an illness thing. So it's so normal that in the English language, it's part of our language. So we talk about feeling gutted when we feel sad. It is a metaphor in English, but we also mean that kind of physical feeling, that sinking feeling in the bottom of your stomach when you feel sad. We talk about butterflies when we feel anxious, and we do mean that kind of fluttery feeling. We all get sweaty, get a raised heart rate when we get anxious. So we all get physical symptoms as a part of experiencing emotion. For some people, that can move into being pathological, i.e. it gets in the way of your life and it's causing a problem because it gets exaggerated. So emotions like sadness and anger are really hard experiences or hard emotions for your body to experience and to tolerate. And sometimes when that gets really, really bad, your body or your brain just says, I can't manage this anymore. I need to protect myself. I'm going to switch it off. I'm going to switch off feeling like this. And I do use a kind of fuse box analogy for that, a bit like your house fuse box kind of hitting a kind of surge point in the electricity and the trip switch going. And then those feelings have to be processed somehow. And we think what happens is that they're then processed down different pathways through your brain. And that can then give any physical symptom virtually that could happen in your whole body can be at least partially related to how you're feeling. And I've seen people from not being able to move their legs or not being able to move one side of their body, which might look like a stroke, but then brain scanning doesn't show a stroke has happened. I've seen people who have seizures that look like epilepsy, where the people have then had a video EEG, which is a test where you have sensors put on the outside of your head to measure your brain electrical activity. And it looks for the electrical activity that is associated with epilepsy. And they've had a video on them at the same time to show the seizure. And when the seizure happens, there's no epileptic activity on the kind of electrical probes. So that it's not epilepsy, but it does look exactly like a seizure. And I've had people have difficulties with talking or hearing, remembering things. I've had people who have chest pain that is not a heart attack. all sorts of symptoms. Virtually any symptom in your body can be at least partially psychologically related. And I think the other really important thing in saying that is that it's not usually a one or other thing. So I think people think of it really in a really binary way. So this is either physical in your body, you can get a test to show what's wrong with you and it's real and genuine. And I'm making inverted commas marks with my hands for the purpose of the podcast, because I don't believe that
of the tape.
because that's not true, to say that the other symptoms are not genuine. Or in society's mind, it's in your head, you're making it up, you're being lazy, putting it on, and neither are true.
I've actually handled a few legal cases with that sort of presentation, where the claimant in the case has some sort of somatic disorder and has transitory symptoms that really impair their ability to work or their mobility, but then they will sort of resolve and then they'll come back again, but they're absolutely genuine symptoms, whether they're organic or whether they're coming from some sort of mental health source.
So for a start, it's usually a bit of both. So there's usually, as I say, physical symptoms are absolutely entwined with emotional symptoms for all of us. It's absolutely, everyone with cancer will have feelings about their cancer. Of course they will. And all kind of emotions have physical symptoms associated with them. So it's never one or the other. It's always both. I think there's physical symptoms which have at least partially a psychological cause are often mistaken for malingering, which is actually extremely rare. So malingering is a known thing that can happen where people are actually making up symptoms, usually for some gain of some sort, like, I don't know, staying out of prison or something like that.
There's usually it
could be legal compensation, but actually malingering extremely, extremely rare, whereas physical symptoms with a psychological cause are extremely common. So I think people always jump to the conclusion that people must be making it up, and that's very, very
it's a really interesting area, actually. So one of those cases that I mentioned, the claimant, at times, she was, I think, a woman in her 50s, and at times she wasn't able to climb the stairs. And then a month later, she'd be disappearing on a sailing holiday. And so, of course, for those of us on the defence side of the case, our suspicion was that she was malingering. But the expert evidence, the psychiatric evidence in that case, was absolutely clear that these were totally genuine and debilitating symptoms. There was no malingering. Interesting. Right, well, we'll leave it there for now, and that's the conclusion of this first part of the two-parter. We'll be back in a couple of weeks with the second episode, in which we're going to be discussing a number of really key issues. We're going to be looking at managing maternal mental health and some of the challenges and features of that work. We're also going to be considering some of the key risk management issues relating to the psychiatric and mental health arena. It'll include a discussion around patient confidentiality, capacity, record keeping, and much, much more. Finally, we're going to be discussing Alice's unique experiences of working as a liaison psychiatrist at the Glastonbury and Reading festivals. So please stay tuned for that, and we'll look forward to you joining us on the second episode of this two-part podcast. It remains for me to thank you, Alice, for appearing on the podcast this morning. It's been an absolute pleasure and a privilege to have the benefit of your company and to hear what you've had to say. Thank you very much.
Thank you for having me.
Thank you for tuning in. I hope you enjoyed today's episode of Altair Talks. If you did, please don't forget to subscribe or leave a like or a review on whatever platform you're listening on, as this helps spread the word. If you have any questions or comments or topics you'd like us to explore in future episodes, please do contact us, as we'd love to hear from you. You can find us on LinkedIn or visit our website at www.altairinsurance.com. Stay tuned for more episodes, and until next time, take care of yourselves. The information contained in this podcast is not intended to represent a complete analysis of the topics presented and is provided for information purposes only. The views expressed are personal to Dr. Ashby and Will Marshall and do not necessarily represent the views of the London Psychiatry Clinic or Altair Insurance. The content of this podcast is not intended as legal advice, and no responsibility can be accepted for any reliance placed upon it. Independent legal advice should always be obtained before applying any information to particular circumstances.